Hello, welcome to CCHP's learning series on telehealth policy 300 series. Today we're going to talk about the Medicare mental health policies for 2022. This will be a deeper dive since some of the policy changes that CMS has made are pretty complicated. Keep in mind when this is being recorded, it is February 2022. We are still underneath the public health emergency, so the policies that I go over are not yet in effect. They will go into effect once the public health emergency is declared over. We are talking about permanent Medicare policies around the use of telehealth to provide mental health policies. So as long as we're underneath the public health emergencies, those emergency waivers around telehealth policies are still in place. However, once the public health emergency is declared over, these policies will then kick in. So regard these as the permanent telehealth CMS policies or Medicare policies. Few disclaimers before we get started. Please note that any information provided in today's talk is not regarded as legal advice. It is strictly for informational purposes. CCHP always recommends that you consult with legal counsel if you're interested in formal legal opinion. We're also not saying that our comments here will lead absolutely to like reimbursement for your services as well. And also note, if I happen to mention a company or show a picture of a product, know that neither I nor CCHP has any relevant financial interest, arrangement, affiliation, or relationship with such a company. So for those of you who have gone through CCHP's telehealth policies 101 and 102, this may look a little bit familiar to you. And these are the four sort of basic issues that telehealth policy touches a lot upon, telehealth reimbursement policy. And definitely the Medicare policy around telehealth definitely touches upon each of these four issue areas, where what type of service is being provided, the location of the patient, the modality in which the service is being provided, and the provider providing that service. And aside from the service, the other three elements are really issue areas that CMS administratively does not have complete control over. These are areas that are really dictated by what's in federal law. So in order to change them or make significant changes to them, they need to actually have an act of Congress, literally. So Congress would need to pass a bill to like change the major barriers that exist within these policies. For example, the location, where right now underneath permanent telehealth policy for Medicare in the Medicare program, the patient needs to be located in a specific type of location, a rural health professional shortage area or non-metropolitan statistical area, and that they have very, very specific types of definition, or within a demonstration project located in Alaska or Hawaii. So to like change from those requirements, you would need Congress to act. It's not something that CMS has total control over. The one area or the one issue where CMS does have a lot of control over is the service. What service is going to be covered and telehealth is used to provide that service. So what we saw for 2022 is CMS really taking advantage of what was in their sort of administrative powers toolkit to try to expand the use of telehealth without having Congress take any action yet, because Congress has not taken up a telehealth bill or telehealth permanent policy at this point. So what do we see? So how did they do this? So CMS usually, when they're making changes administratively, they utilize the physician fee schedule, which is a set of policies that they do every year. They make their proposals in June or July, the year before they are to go into effect. They have a comment period, then they finalize their policies in November, and then they go into effect usually the first of the following year. So for 2022, this all happened back in July of 2021, and they finalized their policy in November. And there was a mix of sort of legislative change and administrative change. So the legislative change came from the Consolidated Appropriations Act, which was passed in December 2020. So basically, Congress had some policy in there regarding the use of telehealth in the Medicare program, and CMS was simply implementing what they had to do because of this legislative change. And then there were two administrative changes that they made on their own without Congress directing them. Now, all of this really centered around the provision of mental health services and how you use telehealth to provide those services. And we're going to go over that right now because, as I said, it was very confusing. It's multi-layered. So we're going to take this step by step. Before we dive deep into it, I do want to stress again, these are policies that I'm going to cover are permanent telehealth policies. So these are policies that will go into effect or be activated once the public health emergency is declared over. Again, currently, as I'm recording this, we are still in the midst of a public health emergency. So these policies are not activated. The telehealth waivers that that CMS put in place are still in place now for the Medicare program. So what we had before any of these changes that are in effect in 2022, sort of like our established Medicare policy for the use of telehealth, is that we had certain restrictions on there. Again, like the issues that I went over earlier, patient location, the modality, the providers providing service, and the services covered. And what we had was a policy that probably a lot of folks are familiar with. Patient needs to be located in a specific type of area, the modality used, what it says in federal law that it needed to be through a telecommunication system. And that's all it said in federal law. CMS added, on their own through the regulations, the word interactive in front of telecommunication system. Now, keep in mind, because this will be important as we go along for the development of policy, that telecommunication system is not defined in federal law. And the word interactive was an administrative decision that CMS made to add in the regulations. But nowhere is there a definition in statute regarding telecommunications system. And why that's important is that's like an area then where CMS has like a little bit of leeway, a little bit of opportunity to like kind of define what it means and what it can involve. Providers, now this is very specific in federal law. There is a specific list of providers where they say these are the providers who are eligible to provide services via telehealth and that Medicare will reimburse for. And this is where a lot of people recognize FQHCs and RHCs are not on that list, so they're not eligible distance site providers. During the public health emergency, there was a waiver to allow them to be distance site providers. But again, that's temporary policy. So we're talking about permanent telehealth policy in Medicare now. And right now they are not on that eligible list, along with a lot of other types of providers, such as allied health providers, PTs, OTs, dentists. The services, this is where, again, I said CMS does actually have a lot of control and leeway. They can say like what services will be reimbursed if telehealth is used to provide the services. And the way CMS does it is they go code by code, like service by service, and saying like, yes, this CPT code, you can do it. This CPT code, you can do it. Oh, this CPT code is not going to be eligible. So there is a specific list then of like codes that, regardless of whether the public health emergency is in place, these codes will be eligible to be reimbursed if the service is delivered via telehealth. Now, what's the first thing we're going to tackle is the change that Congress dictated in the Consolidated Appropriations Act that they passed back in December of 2020. And what they said in there was that, for mental health services, we are going to like not have that rural restriction come into play, and we're not going to we're going to allow the patient to be at the home in their home when they're receiving services. Previously, there was an exception to that geographic home exception that existed prior to the Consolidated Appropriation Act, and that was if you were receiving treatment for SUD and you had a co-occurring mental health condition that was being treated, or if you're receiving end-stage renal treatment. And then there was like a geographic exception for like acute stroke treatment. So with the CAA put in like another exception for mental health. So you didn't have to fall into one of these other sort of pre-existing exceptions, such as you were diagnosed with, or you were being treated for SUD, and then you can also receive services in the home without the geographic limitation. CAA said like, we're going to expand it. We're not going to require you to meet one of these exceptions that already pre-existed here. You can receive mental health services in the home through telehealth, and you don't have to worry about the geographic limitation. However, we're going to put other conditions on that. Before you can do that, you need to like have a 6-month in-person visit with that telehealth provider prior to those telehealth services taking place. So while they did expand it by like making another exception to the geographic rule and like allowing another more services in the home, they put a caveat on there saying like, you need to have this in-person 6-month visit. And that was what CMS was like implementing in their policies. So again, so keep in mind here where patient location, you've got a number of exceptions here. You have kind of like your original telehealth policy, what existed before the CAA, saying like, well, you need to be in this rural area, this rural health professional shortage area or MSA area geographically. That was a requirement you had to meet, or you had to be in these specific types of sites, like a list of specific sites, like a hospital or a clinic, unless you're receiving like these sets of services, which meant you're being treated for substance use disorder and a co-occurring mental health disorder, you're receiving um, end-stage renal disease treatment, then you can have those in the home without the geographic restriction. The CEA added another sort of exception for mental health services, but only if you had the 6-month in-person visit with that telehealth provider prior to those services taking place. So that was one level of exception. And then they added another level, and this involved audio only. So as I mentioned earlier, in statute for delivery of telehealth, they defined it as being delivered via a telecommunication system. And in federal law, that's not defined. In regulation, CMS added the word interactive in front of it, so that kind of takes out your store forward for the most part. But basically, telecommunication was not defined. So CMS, with that leeway there, added audio only into the definition of telecommunication system. However, only when they were talking about the provision of mental health services. So they're going to allow audio only to be used as a modality to deliver those services, but only for mental health services. And they added a bunch of other caveats. Now, I only have here listed that there needed to be a 6-month in-person visit before those telehealth services take place. And then subsequently, it needs to be like once every 12 months. There are other caveats in there as well. There are other conditions. So I just wanted to point this out for the benefit of this, that, you know, there are other conditions here and they're allowing that to happen. And it's, again, another exception, but it's a very narrow exception. They also did the same thing for FQHCs and RHCs, in that they said, we're going to redefine mental health visit to allow live video and audio only to be used to deliver those services to their patients. So again, this was not something that they could do, or because adding FQHCs and RHCs to eligible providers list of telehealth, because that, again, is something Congress would need to do. But what they could do was redefine what a mental health visit meant for these particular entities. And that's what they did. By redefining it, though, even though they're using these telehealth technologies to deliver the services, they're not considered telehealth providers. This is simply like a redefinition of what a mental health visit means for these providers. And then for services, what they're doing is that there are some services that are on the temporary COVID list that they are moving into sort of a holding bucket for CMS's purposes, where they say, like, these particular services, and it's not all of the temporary codes on that COVID list, that they will keep around until the end of 2023. So for example, if the public health emergency is declared over in December of 2022, the codes in that specific list will stick around for an additional year. Again, I want to say, like, all those temporary codes on the COVID list did not get moved over into this holding bucket of CMS. There was only maybe about 40 or 45 of those codes. So there will be codes that go away at the end of the public health emergency, if like it was declared over tomorrow, unless some other policy change is made. So let's look at this a little bit more closely here. So in saying, like, implementing or allowing services to take place either by audio only, mental health services take place via audio only in the home or without the geographic limitation, keep in mind, though, that you're still limited by other policies that are in place, such as the services. So it's not saying that all services now related to mental and behavioral health are reimbursable in the Medicare program if you use live video or audio only. You still are limited to, like, the eligible services that are underneath the telehealth eligible services list that CMS puts out. So keep that in mind as well. It's not all the codes. You would still have to, like, look at the codes on the services list. So these are all policies of, like, one may be relaxed here, but there may be, like, another one that impacts what you can do too. For FQHCs, as I said earlier, how are they able to allow FQHCs to use, like, telehealth to provide services? Again, it was a redefinition of what mental health visit meant for these particular entities. So what that means is that it's not considered telehealth if they do this. So FQHCs and RHCs are not telehealth providers. They are simply doing what they typically do when they provide like a mental health visit. They just have more options now in the modality or the means of which they deliver those services. So it's not considered telehealth. It's not recorded as telehealth. So it also means that they get their usual rate, but it's not recorded as telehealth. It also means that they would need to follow any other requirements or procedures that they typically would follow for provision of mental health visits. So those would still like be in place for them as well too. So what does this all mean? So if you meet the requirements or fall into one of the exceptions that existed before the Consolidated Appropriation Act, you actually don't have to worry about the 6-month in-person, 12-month subsequent in-person visit requirement. It's because you fell into one of the earlier exceptions. So for example, if you had a patient that is being treated for substance use disorder and also being treated for a co-occurring mental health disorder, telehealth provider doesn't need that 6-month in-person visit with them. It's because that exception existed before the CEAA. So think of that as sort of like original telehealth policy. It's stuff that was around before the CEAA was passed. So you don't need to like meet this requirement if you fall into one of those exceptions. If you don't want to fall into one of those exceptions, then yes, and you're providing mental health services, you do need that 6-month in-person, 12-month subsequent in-person visit. And if you're doing via audio only, that also kicks in. And keep in mind that there are other conditions, requirements to meet, especially if you're talking about audio only too. It's not just this in-person visit. There are a couple other things that requirements you would also need to meet. For FQHCs and RHCs, again, this is a redefinition of what a mental health visit means for these entities. So you're not providing the services via telehealth, but those conditions that exist when you're providing mental health services will still apply as well. And then if you are using or you're providing these services to a patient in their home, you do have that 6-month in-person, 12-month in-person visit requirement kick in as well too. There are some conditions around FQHCs doing all of this, a little bit less than like what's required for non-FQHCs and RHCs from like the what I was previously talking about, but there are certain conditions, and basically it surrounds like patient consent on doing this. So those are things to keep in mind here, and also to keep in mind like all these policies that I just went over, they are in effect, but they're not in effect because we're underneath the public health emergency. So as long as the public health emergency is on, you don't need to meet that in-person visit requirement prior to delivery of services, because the public health emergency really does not, sort of takes precedence here. So these requirements don't quite kick in until the public health emergency is declared over. So as I'm recording this as of February 2022, they haven't quite been activated yet. And then, but once the public health emergency is declared over, so if it's declared over February 28th, then the policies go into effect then March 1st, or suddenly that becomes the environment that you would need to like meet, and those requirements that you would need to meet. So you have to keep that in mind too. There are a couple of things around, there's some details that are a little bit vague that hopefully CMS will come out with like clearer directions on and explanations and instructions on. But right now, because we're in the public health emergency, I think they feel like they have a little bit of time to develop those as best as they can. So just to really reiterate this again, as long as we're in the public health emergency for COVID, these requirements have not quite kicked in yet. So you don't have to meet them just yet, but be aware that as soon as the public health emergency is declared over, you would need to meet these requirements to meet these standards here. So I hope this has been helpful to you. I know it's very confusing because it is multi-layered, but hopefully this provided a little bit more clarity. I want to thank you for attending this series, and know that more information can be found on telehealth policy at CCHP's website at cchpca.org. Thank you.